Good evening, everyone. On behalf of Taskment, I would like to welcome you all to Medcast Insights into Healthcare, a learning initiative by Taskment. Today, it's a great pleasure to have with us Dr. John Christopher, who is the consultant cardiologist at Care Super Speciality Hospital, Hyderabad. We welcome you, sir. Sir, we look forward to hear from you on today's topic of discussion, Mexiletine, and Unexplored antiarrhythmic drug. Over to you, Dr. John.
Thank you very much for the kind introduction. And today is going to be a very interesting webinar on a fairly new drug and also a very important part of the armamentarium against arrhythmias, especially ventricular tachycardia. When you look at ventricular arrhythmias, they are a very dangerous phenomena. They are a kind of phenomena where as physicians, we are very afraid, and this has a prospect of increasing the mortality of our patients. So it is a very important issue that we're going to be talking about. And the numbers are looking quite grim. And you can see that in the US, we have around 3 lakhs per year. And the Indian registry, we don't have a very formal accounting sort of panel, but we have this heart failure registry in which about 5% of the patients of heart failure have ventricular arrhythmias, which is approximately about 1.5 lakh to 2 lakh deaths, which is similar to what is there in the United States. Now, when you look at ventricular arrhythmias, there are a couple of things that we look as strategies. The first most common one that we would like to use in the intensive care setting or in the peripheral setting is antiarrhythmic drugs, which are a first line of management of VT. The big advantage is that they're inexpensive, they act quickly, and also in a patient who already has an ICD, it decreases the number of shocks. The problem, however, is that each of these drugs have their own contraindications and side effects, and especially given for long, has deleterious effects on the kidney, liver, and the cognitive system. And some of these drugs are pro-arrhythmic and actually perpetuate arrhythmias. The second important strategy is the ICD, or implantable cardioverter defibrillator. They are excellent when a patient has already had a VT or VF, and the patient has a low ejection fraction, and the patient has had some kind of a sudden cardiac death, resuscitated arrest. The big advantage is it has got a mortality benefit of something like 18 to 20%. However, the pathogenesis of VT is not addressed, and there is a whole amount of morbidity with the number of shocks, the infection, pocket infection, and also it is a little more complex procedurally compared to a routine pacemaker. And of course, the big problem is the cost. It's a huge cost. It's 5 to 7 lakhs, which is not something that an average person can afford. The third is a catheter ablation. Again, the indication is a patient in VT storm or a patient with a structurally normal heart with idiopathic VT. And the big advantage is that if you can isolate the origin of the ventricular tachycardia, you can ablate it and make it go away. So it addresses the substrate, addresses the pathogenesis. And in a patient who already has an ICD, it decreases the burden of shocks and the frequency of shocks, and also decreases the need for antiarrhythmic drugs. However, it's easier said than done. It's an invasive procedure. It is a complex procedure. The number of electrophysiologists who can do an adequate catheter VT ablation are very, very few. And generally, a single ablation does not cause amelioration of the VT. Last is obviously sympathetic denervation. It's useful in refractory VT. It's a great tool to be used when there is no other possibility of reducing the VT. and it decreases VT burden and frequency of ICD shocks. However, the problem is it is invasive. There are procedural complications. It's generally done by the thoracic or cardiac surgeons, and it works just in a couple of patients. And it is, as I said, a last resort. So we have a lot of issues with the various strategies that are there, but the simplest and easiest, obviously, is antiarrhythmic drugs. Now, if you look at the historic Vaughan Williams classification, which all of us in pharmacology in the MBBS have been taught, it's divided into 4 classifications. The first is obviously the sodium channel blockers. Second is the very common beta blockers. Third is the potassium channel blocker. And fourth is the calcium channel blockers. Now, the drug that we're talking about today, Mexiletine, comes as a 1B drug. And the indication here is in a post-MI situation, in a structural heart disease situation of VT. And it has striking similarity to lidocaine, which is a very, very common drug that we use in everyday ventricular tachycardia. Now, what about the approval? Yes, it's good news to say that the US FDA, which is the foremost authority in the administration of drugs or the licensing of drugs, has given a green signal for the treatment of ventricular arrhythmias to Mexiletine. So it is well approved internationally. And it is also luckily approved by the DCGI, and it is used in patients with ventricular arrhythmias, patients with multiple ectopics, and patients who have arrhythmia because of drugs, especially pro-arrhythmic drugs, and also can be used in idiopathic arrhythmia. So there's a wide variety of arrhythmias that it can be used both in structural heart disease and in patients with normal or no structural heart disease. Now, the recommendation comes very strong from the American College, and this is 2017 recommendation. The American College gives it a very strong recommendation to treat ventricular tachyarrhythmias or ventricular fibrillation. Across the Atlantic, the European Society and the Asia Pacific Heart Rhythm Society also gives it a big thumbs up sign for using it in patients with non-sustained ventricular arrhythmias over and above beta blockers. And they've given a class 2B level of evidence, C evidence. It is also given as a drug in patients with structural heart disease, and this is the biggest indication. And those patients with the recurrent sustained monomorphic VT over and above ICD and ablation. And here it gets a little better recommendation of a class 2A level of evidence B. Now, as I told you, it is a first form of lidocaine, exactly similar, but it is orally available. That's a big thing. It inhibits the invert sodium current, and that's why it's called a sodium blocker. And as I am showing you, it is available in the 0 phase, which is the invert sodium current, and it acts on the Purkinje fibers and therefore decreases the ERP. And by decreasing the ERP, it increases the ERP by APD ratio because the APD remains constant and the ERP comes down. So the ERP by APD ratio increases. ERP, as you know, is effective refractory period. The RRP is the refractory period, and APD is the action potential duration. So it is an oral drug. It is a 1B drug. It blocks the sodium channels here, that is in the 0 phase, and opens the potassium channels, therefore decreasing the polarization of the cardiac action potential. So what it ultimately does is reduces the ventricular automaticity by decreasing the ability of the ventricle to send out those VPCs. It shortens both the action potential and also the effective refractive potential. Now, by being a congener of lidocaine, as you know, lidocaine is an IV drug. In a patient with normal conduction system, it's extremely safe. It has a minimal effect on cardiac impulse generation. Patients do not go into second or third degree AV block. There is no prolongation of a QRS. So very safe in person with a normal conduction system. In person with a pre-existing conduction defect, there is depression of the sinus rate, so there is effective bradycardia. The sinus node recovery time, or SNRT, is increased, and there is a slight increase in the interventricular conduction. Now, if you look at all the drugs and compare with Mexelitine, you will see that it is one of the safest drugs that is available, in the sense it is very neutral across the SA nodal rate, the effective refractory period, the PR interval is not affected, the QRS is not affected, the QT is not affected. For example, like in procainamide, sotalol, and even in amiodarone, there's a huge QT interval increase which predisposes them to a frequent arrhythmia. So Mexletine has a very nice, safe effect on the electrical system. Now, what about its effect on the hemodynamic system? Very mild decrease in cardiac output. There is no significant negative inotropic effect like amiodarone, and the blood pressure, heart rate remain unchanged in a patient with a normal conduction system. And therefore, it's a very, very safe drug, even in a hemodynamically compromised patient. Only when you give the initial doses in patients where you want to fast forward therapy, there is a mild depression of myocardial function, which is usually reversible. The big advantage over lidocaine, however, its absorption from the GI tract can be taken orally. It gets into the bloodstream in about 2 hours, average binding to the plasma protein, so it stays long. Its first pass metabolism is low, therefore stays in the system, can be taken as a once-a-day drug, and about only 10% goes through the kidney, so can be safely given even with mild renal failure. Now, the dosages are individualized because it's dose related. It has to be taken with food. In patients where you want a rapid control, you want to give it 200 milligrams, that is the size of the tablet, every 8 hours. And you need to wait for 3 days before making those adjustments. You can go up or down by 50 to 100 milligrams in those patients where there is titration required, or when you want more suppression of the VT. In a rapid controlling of tachyarrhythmia, you need to give 2 tablets, that is 400 milligrams stat. And after 8 hours, you need to repeat 1 tablet, which is 200 milligrams, and continue as per the chronic treatment, which is generally about 200 milligrams once a day. When you don't want a rapid initiation, you just give a single tablet, which is 200 milligrams, repeat it 8 hours. After that is over, after 3 doses, you need to increase the dose to 300 milligrams every 8 hours. And then you increase to 400 milligrams over a 3-day period every 8 hours. And then you can titrate, up titrate, and down titrate depending on the recurrence of the arrhythmia. Cannot give it in a cardiogenic shock patient. You cannot give it when there is more than a 2nd degree AV block. You cannot give it obviously in a patient with complete heart block, especially when there's no pacemaker. And there are some mild GI disturbances and CNS disturbance, as you can see, some acidity, lightheadedness, coordination difficulty, but generally it is well tolerated. Now, the clinical reports are quite good in the sense they are very well tolerated. And if you look at patients with ICD, you can clearly see that before ICD, patients with ICD before Mexletine, there's significant amount of tachyarrhythmias, and after Mexletine, it comes down by a huge margin, which is statistically very, very significant. And again, in patients with ICD, having VT, VF episodes are quite significant, and it drops down drastically when you add Mexletine. And obviously electric storm events, which is a very dangerous thing in an ICD patient, really comes down. So it's a good add-on therapy in patients who already have pre-existing ICDs. As I told you, the tablet size is 200 milligram. In this particular patient, it was given about 3 tablets, and in some patients, 2 tablets were given. So the dose is generally 2 to 3 tablets of 200 milligram size. And most importantly, it has a great role as an add-on therapy over and above ICD. What they did show was the VPCs, paired beats, non-sustained VT really comes down compared to placebo. And when they followed up these patients for long, there is continued effectiveness. Now, in patients with recent MI, we know that one of the reasons they develop a VT-VF or sudden cardiac death are the significant ventricular ectopics. And you can clearly see here that before entry, both the placebo and Mexiletine arm are similar in terms of VPC load. At the end of 1 month, significant drop in the Mexiletine arm, and at 3 months, the drop continues to be significant. And again, here we are having a dose anywhere between 300 to 600 milligrams. And here the fast loading has been followed of 400 milligrams, followed by 200 milligrams every 8 hours. So this is the algorithm that we follow. Patients are put on antiarrhythmic therapy. We look for suppression of VT-VF and suppression of SVT. If the ICD shocks are decreased and they're appropriate for the VT-VF and inappropriate for the SVT, we find that there is an improvement in quality of life and decreased consumption of healthcare resources. In patients where the target tachycardia cycle length is increased, then the VT is better tolerated and you have a better response to ATP on the pacemaker. So 2 things are done by the AADs in patients with ICD. One is they increase the target tachycardia cycle length, makes the VTs more responsive to shocks as well as to anti-tachycardia pacing. The second is they go to the root of the arrhythmia and suppress the VT-VF bursts, and therefore the ICD shocks come down, therefore having a better quality of life. Now, when you look at the add-on therapy or adjuvant therapy over and above amiodarone, you can clearly see that the VT-VF episodes start coming down over the 3 months. The shocks start coming down, the appropriate shocks start coming down, anti-tachycardic pacing really comes down, and most important, electric storm episodes decrease. And this was data from patients who are already on ICD, on amiodarone, and then given Mexiletine over and above. And the dose here was about 300 milligrams per day. So again, in patients with recurrent refractory VT already on amiodarone, you can see that patients have been added Mexiletine to this therapy. Oral therapy has been initiated, and over 6 months, patients have been followed up. And they found in the first 3 days itself, there's a 1/3 reduction in VT episodes, and almost 2/3 by the end of the 1 week come down when you add it on to amiodarone in patients with refractory ventricular arrhythmia. So it's a great drug to add on to in patients who are already on amiodarone and not getting corrected. Now, if you look at the QT interval, as you know, when you have a patient on amiodarone, the QT intervals are quite high. But here, when you add on Mexiletine, you get a 65 millisecond decrease in the QT, corrected QT, which is quite safe. And what they found is that those patients who respond and the VPCs come down, they find that the QT interval comes down by more than 40 milliseconds. And these are the patients who actually do well with Mexiletine. So that is also one way of looking at the efficacy, that if you find a QTC coming down by more than 40, this patient will generally respond to QT, to Mexiletine. Now, in patients with long QT syndrome, which you know is an genetic electrical problem, we find that there is a significant decrease in arrhythmic events on Mexiletine because of its QTC reducing properties. And even the mean number of arrhythmic events per patient comes down by a significant margin with Mexiletine. And this is a very difficult to treat group. These are sometimes small children with long QT, difficult to put an ICD in them. Pocket is a problem. So Mexiletine really gives us time. It buys us time on these patients, and it does it without much side effects. So therefore, it provides an additional therapeutic strategy when you combine it with sotalol in patients with high risk. We know that sotalol increases the QTC. It's very good for some patients, but in patients who already have long QT, additional Mexiletine is a very, very important treatment protocol. So therefore, Mexiletine is a new kid on the block. It's a very important drug in a very dangerous and difficult to treat problem, which is ventricular arrhythmias. It is clearly indicated. It has an FDA approval. It has both the American College behind it. It has the European Society and the Asia Pacific Heart Rhythm Society behind it. So that's a lot of recommendation, strong recommendation, 2A recommendation. It has moderate potency. It's a great drug as an add-on to amiodarone. It's a great drug as an add-on to ICD. But what is more important, apart from the potency, it's got a fantastic safety. It's safe in LV dysfunction, safe in QT prolongation, especially in small children with long QT syndrome. It can be given over a period of time. It does not have major side effects. The effects are generally reversible. It's got a good class 2A and B recommendation by the American and the European societies. And the best part is it can be given along with other antiarrhythmic agents, especially amiodarone, sotalol, and other beta blockers, and also in addition to ICD. The most important thing, it follows lidocaine. It's very similar, and we know lidocaine is a very safe drug. We give it every day in the emergency rooms and the ICUs. But here the big advantage is it is oral. It's available as a 200 milligram tablet. You want a rapid increase in the drug, you give it 400 milligrams and then 200 milligrams 3 times. But if you want to give it comfortably, then you give it 200 thrice a day, followed by 300 thrice a day, 400 thrice a day, and then you settle at about anything between 300 to 600 milligrams per day, depending on the patient weight and the VT responsiveness to the drug. Thank you very much for your patience here. I'll be happy to take some questions.
So we'll request the participants, if they're having any query, they can put in the Q&A box.
Why don't you start off with a question? Since you're very eager to start the marketing of this drug, do you have any queries that I can answer?
So how long we can give it, particularly this drug?
Well, there is good data at the moment for up to 3 years. And as I said earlier, the most important thing of this drug is that it is safe. It is safe and it has a lot of data behind it. So I believe it shouldn't be an issue. And it has only 10% renal excretion. So again, not a major problem with mild renal issues as well. The biggest advantage, obviously, it's oral preparation. It has all the benefits that we have already seen with lidocaine. So I would say it is a perfect match in terms of, rather a perfect mix in terms of efficacy and safety all put together.
Okay.
And as far as I know, we have started receiving these drugs. They are fairly freely available in the market, at least in the metros.
Yes.
How is your distribution been in the tier 2, tier 3 cities?
Yes, so we are penetrating well now, and we are having a field force all over the country, and we are penetrating well now. So it is available in each part of the country. We're making it readily available to the masses.
So I think in a patient who comes with a VT, the standard drug that we give in the ER is Xylocard, which is lidocaine. We give it as a bolus of 50, 50, 50, total 150 milligrams. We start an infusion of 1 milligram per minute. During this time, I think it's a great idea to load the patient on Mexiletine, as we talked about the accelerated loading of 400 milligrams, followed by 200 thrice a day, and then you can titrate from anywhere between 300 to 600 milligrams. So on day 2, you can stop the lidocaine infusion and keep this patient safely on a single drug. The second area where it becomes very useful is that if you have a patient who's not responding to lidocaine, and you started the infusion, and then you accelerate the dose of amiodarone, 150 milligrams over an hour, followed by 1 milligram per minute infusion, then you can simultaneously load this patient up with Mexiletine, because the data is very clear that both drugs are safe. And by the second day, you can stop the amiodarone infusion, continue this patient on amiodarone tablets, as well as on Mexiletine, and your control of VT is going to be pretty good. And when the patient is leaving the hospital pre-discharge, you can slowly cut down the amiodarone, because we know amiodarone has serious side effects on the cornea, on the liver, on the thyroid, especially in female patients. Cut it down by a third and slowly increase the dose of Mexiletine, maybe doing a 24-hour holder either at the time of discharge or at the time of the first follow-up within a week. And if you find that the VPCs are down, the non-sustained VT is down, I think you can safely push this patient on only Mexiletine as solo therapy, or give a very small dose of cordon just as maintenance, maybe 100 milligram once a day, and continue these patients. Do you have a description or monograph of the drug, which the audience can see? Would you like to upload it if you have it? Just to see how the tablet looks like, and it'll help the audience. If you have a picture of the drug or something.
Right now, I'm not having that particular. I'm not prepared with that, so I'm not having particular drug right now. Tablet.
Yeah, so I think if you have the phone numbers of all the participants, I think we can send them a WhatsApp picture of the tablet, the dosage, strength, and maybe a very mini short monograph, so they get comfortable with it.
And monograph I have. I can share it with the people.
Yeah, just you can show the first page so that they're just familiar. And I also think that the physicians who have attended today's webinar should get some free samples so that they can start trying it on their patients, because you know that VT is a very difficult entity to treat, and most of us get frustrated because many of our patients don't respond to the conventional AEDs. So I think we send them some free samples, let them try it on their own, and I think they will be very well rewarded.
So this is the complete product monograph we are having of Mexiletine, an unexplored antiarrhythmic drug. The brand name we are having is the Wellheart Mexiletine 150 milligram capsule form. We are also having a dedicated website of Wellheart, so people can also log into www.wellheart.com. This is the complete roles of Mexiletine in ventricular arrhythmia with QT prolongation. The doses are being very well elaborated here. So I'll share it with all the people who are in the webinar with us, so they can have a look on it.
Sure, I think that's a great idea. I think as we reach out to more and more people, I think we'll have a very good audience for this drug. I think as a cardiologist having about 20 years of experience now, I think this is a much sought after drug. It has enabled a physician in a nursing home, small hospital, to be able to effectively treat this very, very dangerous disease that we call as ventricular tachycardia. And it gives us enough time to stabilize these patients and send them to a higher center for either an ablation or an ICD placement or a sympathetic nerve denervation. So as you've seen here, Wellheart is a very catchy name. It's got a 50 to 150 milligram dose. We generally start with the 50, easy to up titrate it. And we that's about 4 tablets of 50 milligrams that we give 8 hourly. And then we can then use the 150 milligram, that's 2 tablets 8 hourly. And then again 400 milligrams 8 hourly till you get a steady state. The steady state is determined by the patient's weight, the patient's response, the absence of VPCs or VT that comes, and then we can slowly downtitrate it till we get a steady level. The general dosages that we have been using, and they're in the trials, are anywhere between 300 milligrams once a day to 600 milligram, which basically is a 150 milligram tablet which you can have twice a day, or a 150 milligram tablet which you can have 2 tablets morning and 2 tablets night. So very easy to titrate this drug because of its availability in 2 strengths, 50 and 150, and therefore becomes very easy to use. So thank you very much once again for your patient listening. And I think if there are no more questions, we can conclude.
Yes, so I'll conclude the session, sir. And people can also log on to www.wellheart.com for more information on Wellheart. And thank you, Dr. John, for joining with us today. It was really an insightful discussion for us as well as for the listeners. And I would also like to thank all the doctors for being with us and for their active participation during the session. Thank you and have a great day.
Thank you.